for the sake of routine, we all know PCOS is the most common endocrinopathy in young reproductive age group women with a fairly high prevalence. The pathophysiology, the root cause is hyperinsulinemia, which occurs because of mainly insulin resistance, which spirals into increased LH, anovulatory infertility, increased ovarian androgen production leading to hyperandrogenic symptoms and infertility. So my topic is mainly related to the symptomatology, so I'll stick the slides to that aspect only. So the diagnosis is mainly based upon two of the three features which are specified in the Rotterdam criteria, that is oligoanovulation, hyperandrogenism, and the ultrasound picture of polycystic ovaries. If two are present, we make a diagnosis of PCOS, and on these criteria themselves, by themselves, are oligoanovulation and hyperandrogenism. They indicate the symptoms which the patient present with. If we look at phenotypes, there are 4 phenotypes depending upon the combination of the features which are present. The frank PCOS will have all the features, and a combination of any 2 of them will give rise to other 3 phenotypes. The frank PCOS, where all 3 features are present, is the most prevalent type of the phenotype among the PCOS women. If we look at symptoms, the patients present with different degrees of alteration of menstrual cycles, hyperandrogenism in form of hirsutism, seborrhea, acne, infertility, overweight. In fact, 80% of the patients are either overweight or obese, and lean ones are rather lesser in number. And insulin resistance is a fundamental pathogenic component in both obese and lean PCOS. The metabolic and long-term consequences are also well known: overweight, abdominal obesity, dyslipidemia, non-alcoholic fatty liver disease. In fact, we just conducted 1 or 2 theses, and a paper is under review, where we have found a very high prevalence of NAFLD and associated parameters of hepatic, where there is hepatic indices which indicate fat deposition in liver. And the other features are, other metabolic consequences are type 2 diabetes, metabolic syndrome, and in long-term hormone-sensitive malignancy, mainly a high risk of endometrial cancers. Psychosocial issues are also being now given more attention, which are associated with PCOS. That is depressive and anxiety system, eating disorders, body image disorders, stress, sexual dysfunction, and even sleep disorders because of sleep apnea. Lifestyle modification remain the main first intervention because of any symptoms. The management of PCOS is determined mainly by 2 things. One, what are the symptoms, and second, what are the fertility requirement of the patient. Whatever be the symptom and whatever be the requirement, lifestyle modifications remain the first step when we advise, prescribe to a patient. Most important is dietary modification, where one needs to have reduced energy diets. One has to develop calorie deficits so as to achieve weight loss. And the composition of diet also needs to be altered so that to ensure increased consumption of fiber, fruits and vegetables. Behavioral strategies which aid in reduction of psychological stresses are also emphasized. Then there are specific exercise recommendations for patients depending upon the age group in form of physical activities regarding the duration and how they can be done, and what is the, and even apart from the routine exercise, strength training is also being emphasized, because that leads to increased formation of the muscle mass, which consumes more glucose, and it corrects the hyperinsulinemia. 60 to 85% of the patient exhibit menstrual dysfunction, which commonly we will classify as AUBO. And these can be oligomenorrhea, that is, there is increased interval between the consequent menstrual periods, amenorrhea, polymenorrhea when there are frequent cycles, and often patients present with very heavy bleeding following prolonged cycles. So there can be amenorrhea of 2 to 3 months, and that is followed by a heavy bleeding which needs to be tackled on an urgent basis. So the first line of drugs for menstrual irregularities are hormonal contraception, including the LNG IUS or periodic progesterone withdrawal. And the second line are metformin. So most commonly, the way, if you recall how we treat AUBO, it is with progesterone, OC pills or LNG IUS, depending upon the patient's fertility requirement and how severe the bleeding is at that point of time. So the most common drugs that we use are various types of, any type of OC pills can be used to control the bleeding. In my setup, I'll be using what is available in the government supply, but any OC pill will work to control to correct the menstrual irregularity. Progesterone preparation, medroxyprogesterone acetate, norethistone acetate, and LNG-IUS, which is an intrauterine device, any can be used. If we are talking of oral progestogens, then they can be taken for 10 to 14 days every 1 or 2 months, which protects against endometrial cancer. Here the duration is of importance because some of the earlier studies have shown that a minimum requirement is of 10 to 14 days of progesterone to prevent hyperplasia from occurring. So to regularize the cycle, this alone strategy can work. However, progesterone will not control hirsutism if that is present along with. In those cases, COC pills will be better. And also for a patient who wants to prevent pregnancy, progesterone may not be the best of the choices. So in that case, again, OC pills will be better. So based on patient's symptoms, age, fertility, contraceptive needs, and other risk factors, any of these preparations can be chosen to regularize her menstrual cycles. Then hyperandrogenism. These present mainly as cosmetic issues. There will be hirsutism, acne, acanthosis nigricans, androgenic alopecia, and they can be very distressing to the patients. Often patients tolerate menstrual irregularity much, they accept it and they live with it, but excessive hirsutism, acne are much more distressing, especially to the young women. So the first line remains the hormonal contraception. Second line will be various anti-androgenic medications, spironolactone, flutamide, finasteride. Among these, spironolactone is the one which is most commonly used, and personally speaking, I have been using it for almost 20 years or more, and it's a wonderful and very effective drug with minimum side effects. Then eflonothin is a local preparation. It's a cream which is applied and which is used for mild facial hair, present on the sideburns and chin. And then mechanical means like electrolysis, light-based therapies are also very commonly prescribed. And metformin is not that much effective in hirsutism. So metformin should not be the first line drug which is to be prescribed for hirsutism, but it can be given if there are other problems like metabolic issues associated, then metformin can be given. For a patient who is planning pregnancies, then anti-androgen medications should not be given because they have got teratogenic side effects, and then mechanical methods are only to be recommended. So among the anti-androgen, spironolactone comes with the trade name of aldactone. Anti-androgenic effect is there in, it's a 25 milligram tablet, so 50 to 100 milligram can be given. Finasteride is another drug, 5 milligram per day. It's a type 2 5-alpha reductase inhibitor, but spironolactone is given much more commonly. Usually in my clinical practice, I will start with, say, an OC pill, and if OC pill is not showing sufficient effect in 4 to 6 months, then a spironolactone can be added. Alternatively, if it's a severe hirsutism, in those with a very high FG score, and I have ruled out other causes of hirsutism like late onset congenital hyperplasia and other tumors, etc., then right away I may be prescribing an OC pill along with the spironolactone. So the other drug flutamide is used less commonly, and liver functions, adverse effect on liver function remains a major side effect of concern with that particular drug. As for the acne, the first line are hormonal contraception with or without standard topical acne therapy. Now, what is the standard topical acne therapy? It includes retinoids, antibiotics, and benzoyl peroxide, which usually our dermatological colleagues will be prescribing. Second line are the anti-androgen medication, mainly spironolactone, and anti-androgen must be prescribed with contraception because they can cause undervirilization in a male fetus. So wherever we never prescribe spironolactone alone. It is always in combination with the OC pills, because spironolactone can also give rise to menstrual irregularity. So if we are combining it with OC pills, that side effect of menstrual irregularity is taken care of, as well as the anti-androgenic effect. It combines and gives a better clinical outcome. For a patient who is planning pregnancy and has acne, standard topical acne therapy is recommended and not the anti-androgen medications. So just a word about OCPs, since they are almost synonymous with the first-line treatment for PCOS. So they are the first-line therapy for oligomenorrhea, hirsutism, and acne. They have got an estrogen component and a progesterone component, and their mechanism of action is mainly by increasing the sex hormone binding globulin production from the liver. And as it increases, it mops up the excess androgens from the blood. There is decrease in the free androgens. As a result, there is it gives rise to decreased androgenic symptoms, and it also regularizes the menstrual cycle. There is always a concern about the risk of venous thromboembolism with these OC pills. So there is a whole list of drugs is there which have got medium, high, and low risks associated with them. Usually there is no particular OC pill which can be preferred one over other for management of PCOS, and lowest effective estrogen dose should be the OC pills with lowest effective estrogen dose are preferred, taking care of cost, availability, side effect, and metabolic profile of the patient. Like in my clinical setup, I'll be simply using the Malayan, which is freely available in the hospital supply in our clinics. COC pills are recommended in adult women for hyperandrogenic or oligomenorrhea. They should be considered in adolescents with a clear diagnosis of PCOS for management of clinical hyperandrogenism and irregular menstrual cycle. And the cyproterin state-containing drugs should not be considered first line due to adverse side effects, including thromboembolism, and they are preferred for the moderate or more severe hirsutism. The COCP are also combined at times with metformin, but their effect is more when there is a combination of symptoms, like there is hirsutism along with metabolic features. And similarly, COC with anti-androgens I have already discussed. They are useful in patients with severe hirsutism after 6 months or more of combined pills and cosmetic therapy have failed to improve symptoms. It is important that whenever we are even prescribing OC pills, patients should be told that it's not a magic pill. The effect is not going to be visible immediately within week or days. Rather, it will take at least 6 months for her to appreciate as any significant difference in her hirsutism. A simple way of telling them is the way the hair grows slowly, they are going to go slowly also. So that makes them understand, and they do not get exasperated that they are taking treatment and there is no beneficial effect. So it takes about 6 months to assess the effect of the OC pill on hirsutism. Coming to anovulatory infertility, it is the most common cause. PCOS is the most common cause of this particular condition. And not only infertility, even if they conceive, there is increased rate of miscarriage, low birth rate, even after treatment. When we are treating them, and especially with IVF, high chance of OHSS, and in long term, if there is anovulation, there is increased risk of endometrial cancer. So even in anovulatory infertility, non-pharmacological measures remain the first line of advice. 5 to 10% weight loss in overweight and obese women helps in 30% reduction of central fat, improves insulin sensitivity, and restores regular menstruation and ovulation. Weight loss also enhances the effect of ovulation-inducing agents which we might be given. So weight loss should be encouraged prior to ovulation induction treatments, preferably to a BMI less than 30 kg per meter square. The first line of anovulatory infertility are oral ovulagens, letrozole and clomiphene citrate. Second line, one can consider gonadotropin therapy. These both options are combined with IUI often. The third line, one can consider IVF, and the other adjunct treatments are metformin, myonistal, and ovarian drilling in some of the resistant cases. So letrozole is now recommended as the first line for ovulation induction in patients with PCOS, mainly for the reasons listed here. It has monofollicular development, less chance of multiple pregnancy, mainly better endometrial thickness and blood flow, because with clomiphene has got an adverse effect on the endometrial thickness, affecting implantation. So most of us are using letrozole for ovulation induction in women with PCOS. With gonadotropin, when we are using the doses, they are ampules of 75 HMG comes in 75 and 150 units. These are the common doses which are used, but the cost remains an issue. They need to very close monitoring. The daily injections are given, and with close monitoring by ultrasound. And you need some experience when we are monitoring a PCOS patient who is being given gonadotropin. There is no difference in clinical efficacy of different gonadotropin like highly purified or recombinant or this, and risk of OHSS and risk and complication of multiple pregnancies need to be discussed with the patient beforehand. So it is a very delicate balance between how much dose is to be given for how long, and to get so as to get singleton or max twin pregnancy, and a trigger should be avoided if 3 or more mature follicles are present on day of trigger to avoid higher order pregnancy. Insulin sensitizers, these are mainly metformin and inositols, and they are associated with decreased circulating androgen levels, increased ovulation rate, and improved glucose tolerance. Due to coming to metformin first, due to key role of insulin resistance in PCOS, off-label use of metformin has been used for its treatment for many years. Metformin alone in association with clomiphene or letrozole increases ovulatory cycles in PCOS. However, pooled analysis also showed that it does not increase the live birth rate. So that remains the main point. So there was a guideline from ASRM on role of metformin ovulation induction in infertile patients with PCOS. And the salient points are metformin versus placebo increases the ovulation rates. However, no sufficient evidence that it increases live birth rates. It alone is less effective as compared to clomiphene citrate for ovulation induction, pregnancy, and live birth. When combined with clomiphene citrate, it improves ovulation and clinical pregnancy rates, but does not improve live birth as compared to clomiphene citrate alone. Pre-treatment with metformin for at least 3 months followed by addition of another ovulation-inducing agent increases live birth rate. And in clomiphene-resistant subset of patients, when we combine with metformin, it yields better results. The dose of metformin is it comes in a 500 mg preparation or a sustained release preparation of 850 mg. So usually I'll begin with a 500 mg tablet given at night time. GI side effects are a major problem with metformin, and some patients are not able to tolerate them well. So if we start with 500 milligram of a tablet given at bedtime, and then after 3-4 days we increase the dose to 500 milligram twice a day, taken after food, both morning and evening, and then for subsequently increased to 500 mg TDS with meals. That increases the tolerance level, patient tolerated better. Remember, a very prolonged intake of metformin, at times patients are taking metformin for years and years. It can also give rise to B12 deficiency. So it will be good to check upon the B12 levels of the patients if they are on metformin for long term. And at times the sustained release preparation are there, so 850 mg can be given twice a day. That can also work to yield the same dose as 500 mg TDS. Coming to the inositol, there are 9 different stereoisomers of inositol, myoinositol and D-cheroinositol. Studies have demonstrated a role of inositol in metabolic disorders, ovulation, frequency of menstrual cycles. Nevertheless, no studies found a better live birth rate. So that is the main thing. So the Cochrane database says that when using inositol for subfertile women with polycystic ovary syndrome, they reviewed 13 trials, and they said there is a need for further investigation via better quality placebo-controlled RCTs with larger population to say for surety whether inositol is beneficial in subfertile women with PCOS. So, laparoscopic ovarian drilling, surgical removal, it is just a initially we have all read wedge resection was used to treat the patients for PCOS hirsute patient. The mechanism of action is destruction of the androgen producing cells in both follicles and interstitial tissues of ovary, and usually indication is in the patients who are resistant to the oral ovulogens and who also require laparoscopic assessment of pelvis for the indications, for other indications, and previous OHSS has happened. In that case, it may be considered. Ovulation rate, which results in 70%, clinical pregnancy rate 76%, and live birth rate 64%. The good thing is the effect continues. It is not limited to one cycle, but if the patient gets benefit, then that benefit stays with the patient. However, because of the concern about the damage to the precious ovarian follicles, This modality is used rather less often. And how to use is rule of 40 watts, 4 seconds, and 4 punctures. It is not that we do multiple punctures and burn out the whole ovary as used to be done many, many years back. IVF, when we are doing IVF, antagonist protocols are used, and we target for decreased duration of stimulation. Total gonadotrophin dose with which we begin is usually less, at about 150 unit of gonadotrophins. And antagonist protocol is beneficial because compared to agonist, there will be decreased incidence of OHSS. And antagonists need to be started early because they can have an early LH surge. The trigger we give for triggering the ovulation is the agonist trigger, and we do elective freezing and frozen transfer in the next cycle. Metformin treatment before and during IVF or ICSI in women with PCOS. The Cochrane says that they studied 9 RCTs, including 816 women, and there was a higher clinical pregnancy rate when using metformin and lower risk of OHSS. So it may be beneficial in women who are undergoing IVF or ICSI. So it is used. The use of metformin in IVF is also because of the reduced risk of OHSS. Dose is 1000 to 2550 milligram daily from start of down regulation. This is, I think, they have taken from some of the other study. Down regulation we are doing in agonist cycles. In antagonist, we are not. There is no down regulation, and we are rather starting metformin even much before, 2 to 3 months before starting our treatment, to get that benefit of controlling hyperinsulinism in these patients. Now, even if the patient conceives, it is not that she is going to have a smooth journey. Complications are known even when a woman with PCOS conceives. So what are these potential complications and their implications for clinical practice? I have enlisted here. Sorry. They can be spontaneous miscarriage, gestational diabetes, hypertension, preterm birth, and fetal growth abnormalities. Then what to do, how to reduce these incidences? If you will see, in all, it is advised weight reduction prior to pregnancy. So many a time when we are taking these patients for fertility treatment, it is of utmost important that we emphasize weight reduction is important, not only to achieve ovulation, to achieve fertility, to achieve pregnancy, but also to take home a healthy baby without these complications. So for spontaneous miscarriage, it is advised weight reduction prior to pregnancy. Diabetes, advised weight reduction prior to pregnancy. Early screening for diabetes. For hypertension, again advised weight reduction. Early screening for hypertension in pregnancy, consider low dose aspirin. Preterm birth, again weight reduction, consider ultrasound scans for cervical length measurement. Fetal growth abnormalities, advise weight reduction, regular fetal growth scans, and consider ultrasound scans for cervical length measurements. All things are weight control is of utmost importance before a patient embarks on pregnancy. Metabolic problems. Various metabolic problems I had enlisted earlier: obesity, metabolic syndrome, fatty liver. And metformin in a daily dose of 1500 milligram or higher should be offered to patients with PCOS and metabolic abnormalities like dysglycemia, dyslipidemia. Other options are inositols, anti-obesity drug, and bariatric surgery. As for anti-obesity drugs, sibutramine and orlistat are the primary drugs which are in use. They are considered in adults with PCOS for management of obesity in addition to the lifestyle modification. Pregnancy needs to be avoided while taking these drugs. So in young women, their role becomes a little restricted. Cost, contraindication, and side effects need to be considered when prescribing these drugs. And mostly it's not the gynecologist who will be prescribing this, it will be the endocrinologist who are more into prescribing, or the internal medicine person. Now, what is the role of bariatric surgery in PCOS? The indication of bariatric surgeries are high BMI. So it can be, if BMI is more than 35, along with some complication, then it can be used. If it is more than 40 kilogram per meter square and failure of non-surgical treatments, and if BMI is very high, more than 50 kg per meter square, then it is the first line. It's still an experimental therapy in women with PCOS, if you think. Meta-analysis showed that obese women suffering from PCOS with bariatric surgery presented a significant decrease in testosterone levels, and that led to correction of and correction of menstrual irregularities also. However, currently there is no strong evidence suggesting that bariatric surgery improves the pregnancy rate in women with PCOS. And of course, we have to be mindful about surgical complications like intestinal incarceration, lack of vitamins, as it gives rise to malabsorption because of the decreased surface available for absorption of nutrients. And so management of comorbidities. There are many other subtle metabolic comorbidities which probably as gynecologists we may not pay much attention to, but we need to, because these are the silent, even the patient is presenting with symptoms, but these comorbidities are lurking in the background and are going to affect her long-term health. So it is important to assess the glycemic status at baseline using oral glucose tolerance test, fasting plasma glucose level, or HbA1c levels, and they need to be repeated. An yearly repeat would be a good strategy. Patient should be counseled about smoking cessation if that is applicable. Obtain a fasting lipid profile in all patients, and this needs to be repeated based on hyperlipidemia and global cardiovascular disease risk. Perform blood pressure measurement annually or more often based on what is a cardiovascular disease risk. Screen for cancer according to universal recommendation. No additional screening is recommended like for endometrial cancer. The best thing would be to see that she is getting regular periods every month or at least once in 2 months, which will decrease her risk of developing endometrial cancer because of chronic anovulation. Screen for depression and screen for sleep apnea, because obesity in these patients is also associated with poor sleep quality, sleep apnea, and daytime sleepiness. So the screening is recommended. So coming to the key points, PCOS is a reproductive endocrinopathy. No single unified treatment is available for PCOS. Treatment should be individualized and adapted to the patient. And there is no single drug for PCOS. Drugs are given according to the patient's symptoms and her requirement, her fertility requirement. Lifestyle modification, including calorie restriction and increased physical activity, is the foundation of therapy. Targets for pharmacological treatment include biochemical and clinical androgen axis, menstrual irregularities, anovulation, insulin resistance, and metabolic profile. In patients who do not want to become pregnant, oral contraceptives are first line of therapy for menstrual irregularities and dermatological complications such as hirsutism and acne. No specific OC pills are preferred, but OC pills containing lowest effective doses of estrogen of about 20-30 microgram of ethinyl estradiol should be preferred. OC pills containing anti-androgen progesterone, third and fourth generation progesterones are drug of choice for hirsutism, acne, and alopecia. Anti-androgens such as spironolactones are often added to oral contraceptive pills as second-line agents for hirsutism. In patients who want to become pregnant, first-line therapy is letrozole for ovulation induction. Metformin added to lifestyle management is first-line therapy for patients with metabolic complications such as insulin resistance. Patients with PCOS are at increased risk of depression and obstructive sleep apnea, and screening is recommended. Thank you.
Thank you, Dr. Deepti. I think you've covered it so well that each and every aspect, each and every problem with which patients come to us, you have explained it. But obviously there are certain gray areas and some people are raising hands. So before we take 2-3 questions, I will request Dr. Sharda Jain ma'am, Dr. Brigadier Sharma sir, Dr. Jyoti and Shalini to give their comments.
I think Dr. Goswami has, as usual, we don't have anything to comment, but her lecture has made this platform so crowded that I got 50 calls in this meantime. So this shows the popularity of things. So I will ask Brigadier Sharma to speak. I have nothing to speak.
Thank you, ma'am. In fact, when I was seeing the number of audience, stopping at 100 and not growing, so that shows people were anticipating, good lecture.
Our platform is 100. Our platform is 100.
Yeah.
Can I barge into it? I had put this link in my master class and I'm getting constant messages. We can't join because 100 is the bar which you have put in this.
Yeah.
There are 200 people who are waiting still. So I told them I'll take a separate class. Don't get into this.
That's it. That's the only thing. But we are really delighted, Dr. Abha. Please keep coming, We will, we will have
No,
this
it
is,
just
this is a free platform. For 100 people will pay and make a platform.
And we will have to increase the capacity.
yeah, to
Yeah, that's it.
400 because I do have 300 to 400 people who join my master
Good,
classes.
good.
So
Thank
they're
you.
all pinging me, all this while, ma'am, we can't join. I said, I'll take another class.
So nice, man. Dr. Goswami, you mentioned 2-3 times about the cervical length in PCOS pregnancy. Is there any link of cervical length shortening in the PCOS?
The link is, sir, preterm births are found to be more common, though etiologically it may be related to the obesity in PCOS women. So that is why cervical length screening is related to more to screen for preterm birth, which is more common in women with PCOS who often are obese.
So it's the obesity possibly, yeah.
Obesity, basically.
Yeah. And secondly, there is some people, say, okay, don't take any dairy products. What is your take on that, in PCOS?
There is no evidence which says that dairy products are going to have any adverse effects. So such a dietary recommendation is not evidence-based.
Okay, thank you.
Excellent presentation, Dr. Deepti. The way you have covered everything you have covered in just 30 minutes and giving such good take-home messages. So, and very well highlighted the very important point, ma'am, that because we see prescriptions in our OPDs that metformin is being given right, left, and center. So I would just request you to, ma'am, please highlight it again, the specific where all the metformin should be used, and it should not be used as should not be overused. And second, the role of metformin in pregnancy. Yes, we all know that it is replacing insulin. So ma'am, just kindly highlight the role of metformin.
So metformin is mainly for the metabolic component. See, the key problem in PCOS is hyperinsulinemia. The job of metformin is to decrease hepatic glucogenesis. It is going to decrease that process and attack on the root cause of hyperinsulinemia. So this is to be used mainly more in obese patients with metabolic syndrome, patients who are embarking on pregnancy, and we can give them for 2 to 3 months prior to that to improve the chances of ovulation. And it combined with the oral ovulogens, it can enhance the effect on ovulation and pregnancy. So for this reason that metformin is indicated. But if patient is if we think metformin is the main thing and there is no need for lifestyle management, because patient may think that I'm taking metformin is going to take care of all my problems, including diabetes, including weight. And that is not going to be that message has to be clear. Patient has to make effort to lose her weight by achieving calorie deficit, by her exercise. And metformin is not the drug just to, it's not an anti-obesity drug. So it has to be, and I like to get LFT done for my patients whom I'm starting on as a baseline metformin. Ultimately, it's going to act on liver. And secondly, long-term complication in terms of B12 deficiency, one has to be mindful of that. So it's always good to ask the patient for how long they have been taking metformin.
So once a patient conceives on metformin, ma'am, she's already on metformin for whatever reason, and we don't find there was some evidence of metabolic syndrome. So in pregnancy, do you continue or do you stop?
Because I won't be continuing. In fact, unless there is a definite indication, I won't be continuing.
Yes, ma'am. Thank you very much, ma'am, for giving this nice message. And
what about ionositol, Dr. Deepti? Ionositol, if somebody is giving...
I'm not using them in my clinical practice. At least I'm not using as of now. I don't know as the evidence emerges. And there is more to it. If I feel more, we all as a community feel more convinced, then only we should be putting it into the use.
But no,
Abha, ma'am, your experience with ionositol,
there is a group of patients who are not able to tolerate metformin and they have insulin resistance. So what about those patients?
We are not using ionositol at all. Once it comes in the guidelines, we will use it.
Ma'am, let's ask Abha, ma'am. Abha, ma'am, your experience with ionositol?
I don't use it at all.
Okay. So I think the message is quite clear.
I think, yeah, Dr. Jyoti?
Yeah, thank you so much. Thank you, Dr. Deepti. It was wonderful. since we get more of adolescent PCOS these days in our clinics, and if they have metabolic features, how frequently should we be doing the lipid profile and their OGTT and blood sugars? How should we follow them up? Since other things are very clear, we know how to put them for hirsutism, how to treat them, OC pills, and other infertility. We all have now come down to letrozole, lifestyle, and everything. Everything is now very, very clear about the PCOS guidelines. But about these adolescents, how frequently should we be following their blood pressures and their other metabolic features, the lipid profiles and everything? And how early can we start them on OCPs?
See, first of all, I would say before you put a label of PCOS on an adolescent, we better be alert about what are we just seeing an ultrasound. So many young girls, even from my own family, they send me an ultrasound report. Oh, Didi, my daughter has got PCOM. And I say it's just a PCOM morphology. There's a word called PCOM, polycystic ovarian morphology, which is visible in a young adolescent girl on ultrasound. But if remember your autotime criteria, and if there are cycles are regular, there is no hirsutism, please allay their fear and don't put a label of PCOS. Plus, I would still in these young girls, I would emphasize on the lifestyle management first. This is the most common, this is a rampant, it's like an epidemic. It is all, everybody screen bound, homebound, no physical activity, lot of junk food, lot of Swiggy, lot of Zomato, and the result is the PCOM. I mean, it all flares up. So as for the screening, I've said we screen it once, but we don't have to do it every 2 to 3 months. So once you screen it, you find, usually we won't really find high blood pressure in young adolescents. It takes time to develop. And there will be some dyslipidemia that we will see in these patients. They can be told it is the lifestyle management which is going to make a huge difference instead of piling them up with lot of drugs. So for young adolescent, I'll go rather slow in starting drugs. For say, if it's a 13-year or 14-year-old girl, I would like to start OCPs. They will be coming to me with mainly menstrual irregularities. Even hirsutism, if it is occurring in 12 or 13-year girl and it's occurring rapidly, I'll be thinking of other causes than PCOS. So in young girls, giving estrogen affects the disclosure of the epiphysis. So we won't like to start them so early. I usually manage my young girls who are presenting with AUB mainly with progesterone. Mainly, and even then, even among the progesterone, we have two preparations. Norethistone acetate is much better hemostat than medroxyprogesterone acetate. So please use that drug more often to control. Suppose they're coming, like we manage AUBO. So when they're coming with heavy bleeding, this is the typical puberty menorrhagia or something like that, they will come. In that case, you have to give them a dose of say 10 milligram thrice a day norethistone acetate, and that we continue for 21 days. Then we give a break, let them have a progesterone withdrawal bleeding, and then put them on cyclical progesterone, which I said need to be given for at least
14 days,
yes,
10 to 14. Right.
10 to 14. Usually I'll peg around 12 to 14. I mean, so what I do is, one interesting point is, you don't know when to start. Whenever my residents are also prescribing, okay, ma'am, so 5th day of bleeding, I should start this. No, they don't have a cycle. They are acyclical patient. So what I do is I start from the calendar month. So 1st to 12th of every month, they are going to take this norethistone acetate. 1st to 12th of March, 1st to 12th of April, 1st to 12th of May, and they can forget about everything else. This itself is going to regularize their menstrual cycles, and it is going to be, patients are going to adhere and be more compliant once they know that they don't have to remember which day of withdrawal bleed, 5th day, 6th day, they are going to start progesterone. They simply start from 1st to 12th. They take progesterone from 1st to 12th of each calendar month. Give them for 6 months, advise lifestyle management, take that baseline lipid profile, show them that this is here where things are going wrong, this is your waist measurement, this is what it should be, and you need to reduce it, and you can actually control your problem without using any drugs. That itself is a big motivator for the patient, for the parents, that they can control their symptoms without even using drugs. So with adolescent, the strategy has to be a little different than for more mature women.
So I think progesterone should be first line rather than OC pills for these adolescents to regularize the cycle.
Yes.
True. Okay. Right. Thank you so much.
Yeah, can I just make a comment?
Yes, ma'am, please.
I think, Deepti, you have really very nicely clarified all doubts. And this is so important to make everyone understand that OCPs are not for these young girls. Another thing I want to clarify, that what normally I do once the diagnosis of PCOS is established, say by the age of 16, 17, 18 years, after that, every year we do a blood pressure assessment, OGTT, and maybe a lipid profile if there is metabolic syndrome in the family. And a weighing machine should be in the house, which she can weigh on every 7 days, so that the moment the weight starts going up, that is when she can curb it. Once she goes up 10, 20 kgs, it's very difficult to come down. And for Sunita, your question that those who don't tolerate metformin, start giving them at night after dinner. They'll tolerate it much better. You can break down the dose. First, give them like 500 milligrams bedtime, then 1000, and then 1500. They can take whole of the dose in the night. This is my practical experience. But in the daytime, a lot of girls just don't tolerate metformin. They are very pukish and they have very low energies. So those who don't tolerate metformin, you can make them tolerate by gradually increasing the dose.
Ma'am, this is my standard practice. I start with the night dose, always and always. But still, there is that 1% class which will start puking. They will not be able to
So
tolerate.
just
And
let
if
them
they
go
have
on
insulin
lifestyle.
resistance,
Then
then
they
we have
need
to,
go on
then we have to
lifestyle.
think of not giving them metformin.
Yeah.
Right, ma'am. So thank you all chairpersons, Dr. Abha ma'am, Dr. Deepti, for a brilliant talk. And let's move on to the